Hello everyone and welcome to our introductory session for PLAB 2 exam. Before we start, because many of people send me messages talking or asking about what do I provide and about the courses as well. So what I'm going to do is a quick introduction about myself and about what do I provide in the courses, and then we will enter into the core of the session. All right? Okay. So, this is Dr. Sahar Ali. I am working in the NHS in acute medicine unit in one of the hospitals in UK. I am also a simulation faculty for the junior doctors in my trust. I am a PLAB 2 instructor for more than 4 years now, alhamdulillah. I have helped hundreds of people to pass their exam. Many of them passed the exam from the first attempt by just relying on the course without any additional courses or academies. Alhamdulillah. I am the founder of PLAB 2 Warriors groups. In these groups, I do provide PLAB 2 Warriors courses, PLAB 2 Warriors one-to-one mocks, and free mocks as well. And all of them, alhamdulillah, are rated as outstanding. These are some of the wonderful success messages and the feedback about my courses. Hopefully, inshallah, we celebrate your success soon in my group, either by taking my course or any course, any other course, or without any course. You can have a look quickly. Right? Regarding my courses, I do have the full course and the practical course. In the courses, you will find high fidelity simulated scenarios. The scenarios are done by me using the 8 minutes bell of the GMC. So you can feel the pressure of the time management, and also you see how the station should be done in the exam. All right? In the practical course, you find the SimMan and the monitor. I use them so you feel the pressure of dealing with acutely unwell patient in a simulated scenario. I use also the mannequins to do the examination on them, teaching cases as well. In my course, you will benefit a lot from the mind maps. They are lovely, systematic, organized, to the point, and easy to remember mind maps. In each case, you will find its mind map. As you can see, the mind map is divided in 2 halves, as the station should be done. Half for the data gathering and half for the management. All right? In the data gathering, you will find the most important points that you can't miss in each specific case. All right? I highlighted everything that you should ask in each case in the data gathering, in examination as well, and in the investigations. Okay? In the management, you find the diagnosis. I give you an idea about how to deliver the diagnosis properly to the patient. And also in the management point based on each case. The courses are designed to take you from scratch to pass your exam, inshallah, provided that you follow and implement all the components of the course. Number 1, the study plan. Number 2, watching all videos from first video to the last one. Number 3, practicing as you go. Number 4, attending and participating in the regular mocks. And lastly, keeping an eye on the course groups and updates. Also, I am currently preparing for 3 big new services, which will be introduced very, very soon, inshallah. These new additional services will make the course even more comprehensive, beneficial, and more value for money. Alright? For the free materials, you can subscribe in my YouTube channel. Just click on the playlists icon. You find many playlists with many useful videos. For my videos, you find 2 playlists. One for the free mocks, and the other one is for the exam marking criteria, preparation tips, and also tips before your exam. All right? So this is for the YouTube channel. Let's dive into our core for the session today. Just a second, doctors, please. Yeah, all right. So let's talk about our plan first. Giving a plan is always important. It allows people to know what is the next step in an organized way. If you succeed to give a plan to your patients in the exam, you will have very high marks in the management. So always try to give a plan. So what is our plan for today? We are going to talk about the format of PLAB 2 exam, marking criteria, the NHS system, and golden tips for preparation. Why you need to know about the PLAB 2 exam and the marking criteria? Because they are the core of the exam. And no one will teach you the marking criteria like this. Unfortunately, most of you are concerned about the sources and the studying. And most of you ignore the importance of knowing the exam and the exam marking criteria. As I mentioned, they are the core of the exam. You have to know the marking criteria and what is required from you in the exam before knowing the sources and the material. All right? Why NHS system is important? Knowing the NHS system will give you an adequate insight about the referrals in the NHS system. So you will know what is the next step in the treatment for each case. All right? Then we can talk about the tips or golden tips for preparation. Okay? All right. Let's start by the exam. PLAB 2. PLAB 2 is the short form of Professional and Linguistic Assessments Board. Professional means that this exam tests your competence and skills as a professional FY2 doctor. Your skills in dealing with your patients and your skills in dealing with your colleagues as well. Linguistic means that this exam tests your language with your patients and your colleague. How you are going to be approachable, understandable, and simple to your patients. How you are going to be supportive and friendly to your colleagues. Alright? The exam covers everything a UK trained doctor might expect to see on the first day of foundation year 2. So, the cases that you are going to have in your exam, you will face them on day 1 once you start practicing. That's why it is important to go to this exam. Alright? It tests your ability to apply knowledge to the care of patients, not how well you can remember and recite facts. This exam is totally different from any exam that you had before. The exams that you had before were testing your knowledge and your ability to recite facts. This exam tests your ability on how you are going to convey this knowledge in an understandable way to the patients. It tests you also on how to build or formulate a management plan for the patients. In your practice, you might face 10 patients in one day. 10 patients. The 10 patients have the same disease. The medical treatment will be the same, but the plan of management will be different. Why? Because the patients are different. The patients are different in their attitude towards the disease, in their circumstances, in their worries. Okay? Some of the patients will be worried about this disease. Maybe he is worried about his life after the disease, or his work. Some of them are not worried, but they just can't accept that they have disease. All right? So while you are making the management plan, you have to include the points that you need to show the examiner for them to know that you are building the right plan for the right patient. Okay? Let's say that this patient is worried about his work. So you have to know what he works exactly, and what are the worries of him, and then you can think together about how to support him in his work. All right? This is a small example. Let's say also another patient who is worried about his lifestyle after the disease. So you need to include in the management plan some tips for this patient about his lifestyle. Okay? So it's really important to formulate this management plan to the patient. You will know more and more while you are practicing and while you are learning, okay? But I'm trying to highlight the important points for you to know before you start studying, okay? All the questions relate to current best practice. You should answer them in relation to published evidence and not according to your local arrangements. So, when you make a management plan, it should be based on the NICE guidelines. NICE guidelines are the guidelines which are followed here in UK. You are not going to follow the guidelines in your home country, okay? Not the guidelines in your home country, the NICE guidelines, okay? These paragraphs are taken copy and paste from the GMC website. If you want to know more about more tips and things about the exam, just visit GMC website and also watch my introductory videos about PLAB 2. Okay? Alright. Let's talk about the exam itself, the exam format. You will have 16 cases. In each case, you have to spend 9.5 minutes. Alright? 1.5 minutes for you to read your question before you enter the cubicle. So in the 1.5 minutes, you will read the question. The question will be on the wall. You will read the question. You will prepare your mind. And then you enter the cubicle in this room. Alright? In the room, you will spend 8 minutes to do the case. So each case is 9.5 minutes. In between the cases, the 16 cases, you will have 2 rest stations. Okay? The exam will be conducted in 2 different buildings, Hardman Street or Hardman Square. How are you going to know where exactly your exam? From the GMC confirmatory email. The GMC will send you a confirmatory email by your booking. In this email, you will find your GMC number and the place of the exam. Is it street or square? All right. The exam settings. You will have face-to-face consultation, phone or video consultations, practical cases. In practical cases, you will have Simman, which is the talking mannequin, examination cases on mannequin, procedure like cannulation or catheterization on a mannequin. In addition to that, you might have examination case on a real patient. And lastly, you will have prescription writing cases. Okay? The exam frame. There is no specific frame for the exam, but let's talk in general. And before we talk in general, I just need to give you an idea about the approaches that you will learn in PLAB 2. What are the approaches? We have 14 approaches in addition to the practical cases. What are the 14 approaches? History-based approach, in which that you are going to deal with a symptom. A patient will come with a symptom and you have to reach a provisional diagnosis. Okay? This is the first approach. The second approach is test results approach, in which you will have test results and then you need to explain the test results to the patient in a simple way. We have surgery approach, in which that you are going to do a pre-operative assessment to the patient. Counseling approach, in which that you are going to give an advice to the patient on the treatment or on their medical problem. We have also dementia approach, in which that you are going to talk with dementia patient or dementia relatives. Okay? Psychiatry approach, in which that you are going to deal with psychiatric patients, maybe depression, psychosis, alcohol and drug misuse. All right. Also, we have ethics approach. In ethics, we have 6 modules: angry patients, demanding patients and relatives, refusing patients, breaking bad news, explaining medical errors, and colleagues. This is for ethics. Then we have gyna cases, gynecology and obstetrics, and pediatrics cases. In addition to these 14 approaches, we have the practical cases. What are the practical cases? The examination on mannequins or real patients. Also teaching, in which that you are going to teach a student something. Procedure, like cannulation and catheterization. Prescription writing, and simman. These are the practical cases. Okay? So, if we talk about the frame generally, you will have 3 of history-based cases, including psychiatry, gyna, and pediatrics. 1 or 2 test results cases, 2 or 3 counseling cases. You have to have ethics. You might have angry and demanding, or too angry. You might have refusing and errors, or too refusing. You might have 2 colleagues. There is no specific frame, but you have to have ethics in your case, in your exam. Okay? For the practical, at least 1 examination, at least. Okay? And 1 procedure, at least 1 prescription, and 1 simman. Okay? For your exam, you will have 1 simman. Okay? This is in terms of the general frame of the exam. Let's talk about the marking criteria. Why you need to know about the marking criteria? Because simply you are going to have this exam. You have to know what is required from you in the day of the exam, what they are looking for in the exam as well. Okay? If you don't know these, you might go to your exam, you might do many mistakes that you don't know that they are mistakes. You fail and you don't know why you fail. But if you know these important points, you minimize the chances to fail. Okay? So we have quantitative mark domains and qualitative. What is the difference between quantitative and qualitative? Quantitative are the numbers that you get in each domain. Qualitative gives you an idea about where exactly the defect in your performance in each case. You have 10 skills areas in each case. If you have a tick under one of the skills areas, so the defect in your performance was in this skill. So if God forbid you fail, so you know what exactly was the defect, so you improve it while you are practicing again. Okay? In the quantitative mark domains, we have 3 main mark domains: data gathering, management, and interpersonal skills. In data gathering, the numbers or the marks are 4, and 4 for the management, 4 for the interpersonal skills. The total marks are 12. So each case, the total mark for each case is 12. Okay? In data gathering, you will be marked on what? On taking relevant history, on doing relevant examination, on ordering the relevant investigations, and put 100 lines under relevant. You have to be relevant. You have to be relevant. When you take your history, you have to ask the relevant questions. When you examine, you have to examine the relevant examination. When you order investigations, you have to order the relevant investigations. And during the course, I teach you in each case what are the relevant points to each specific case. Okay? In management, you will be marked on giving a provisional diagnosis or range of working diagnoses. And we are going to talk about the diagnosis here. You will be marked on also giving a plan to the patient, appropriate management plan. Also, you will be marked on following the patient up. Following the patient up. Okay? This is in terms of the management. In terms of interpersonal skills, you will be marking on what? On building a very nice rapport with your patients or your colleague, and on asking ideas, concerns, and expectations. If you manage to do all of these in the cases, you will get 12. Okay? This is in terms of the quantitative mark domains. Let's take an example for this. If a patient is presenting with eye symptom, let's say that this patient is presenting with eye pain. Eye pain. So when you take your history taking, you have to ask the question which is relevant to eye, like watering, redness, like itching. Okay? In examination, you have to examine the eye. You don't need to examine general physical examination. Eye. Okay? Investigations. If it's relevant, if there is something relevant in the investigations, you can order the investigations. If it's not relevant, no investigations for this case, you don't need to investigate. Okay? In the management, if the patient has loss of vision, okay, with eye pain, so based on this, you will give him the provisional diagnosis that you think about. You explain to him that you have this problem. And then you tell him what are you going to do for him as a doctor. And then you give him an advice about what he can do for himself. This is the plan. What we can do to the patient as doctors and what the patient can do for himself as a patient. Okay? Then you follow the patient up. During the case, you have to start the station in a very nice way, a friendly way. If the patient is in pain, you acknowledge, you tell him, I can see that you are in pain. Are you comfortable to talk? Do you need any help? Okay. And then you ask ideas, concerns, and expectations. You ask him, do you have any idea about what might be the cause of your eye pain? Do you have any concern today? Any expectations from the consultation today? This is how you should do the station. Okay? In the qualitative mark domains, we have 10 skills areas: consultation, diagnosis, examination, findings, issues, language, listening, management, rapport, and time. Let's talk about each one thoroughly. In consultation, you have to have jointed, organized consultation, You have to show that you are asking your questions for a reason. You have to avoid being scripted. How we fulfill this? How to have jointed consultation. Can I ask Dr. Sameh Karam just to avoid writing on the screen? Thank you so much. Because it is distracting me and distracting others. Thank you so much. Yeah. Okay. So in consultation, as I mentioned, we have to fulfill 3 main points. How to have jointed, organized consultation. We all know that the history taking is present history, past history, personal history, and something called 4Ps if the patients are female, and psychosocial history. If you manage to go smoothly from the present history to the past history to personal to 4Ps to psychosocial without any hesitation, you will have jointed organized consultation. But if you take some of the present history, some, not all, and then you jump to the personal history, you take some of the personal history, then you come back to take the other parts of the present history, then you jump to take psychosocial history, then you go back to take past history. So this is a disorganized way. If you do this, you will have a tick in your consultation. Okay? This is in terms of being jointed, organized. You have to show also that you are asking your questions for a reason. What does that mean? When you explore a symptom, when you ask the questions, when you explore let's say that we have a patient who is presenting with a chest pain. Okay? Chest pain. We know that the exploration of any pain is in a mnemonic called Socrates. The site, the time, does it go anywhere else, how bad is the pain, and these things. Okay? Most of you ask these questions and they don't know why they ask. They ask just for asking, just for showing the examiner that I am asking. And the examiner will know that this doctor is asking just for asking because this doctor doesn't use the information in the management. Okay? We have taken an example which is chest pain. We ask about this, the site of the chest pain. Why? We need to know, is it central or is it in the right side or the left side? If it's center, we think about myocardial infarction. Okay? If the pain is in the right side, so we don't think about myocardial infarction. All right? If we ask about where exactly the pain going, is it going to the jaw or the shoulder, to exclude myocardial infarction? We ask how bad is the pain or the grade of the pain. You ask from 0 to 10, how can you grade your pain? If the patient tells you 9 and you don't give him painkiller in the management which is appropriate to this severe pain, so the examiner will know that you are just asking for asking. Okay? So each question in the exploration of each case is for a reason. All right? This is in terms of asking for a reason. How to avoid being scripted? Let's take an example of this. There is a well-known case. This case is 2 weeks confusion. The patient is presenting with confusion for 2 weeks. And this confusion is a side effect from a medication called oxybutynin. Oxybutynin is used for benign prostatic hyperplasia or for urinary incontinence. Okay? All of the doctors know this station. Some of you will enter the cubicle once the patient tells them, I do have confusion for 2 weeks. And because they have this background that this is a side effect from a medication, the first question that they will ask is, do you take any medication? Do you think that this is a right way to approach this case? No, this is not the right way. The right way is starting by exploration the confusion, asking the patient, since when you have this confusion, is it getting worse? Anything that makes it worse, anything that makes it better, any specific thing happened before this confusion? And then you can ask about medications. Okay? What else? In the same case, the patient will raise a concern that he is concerned about dementia. He's afraid of having dementia. And because you know that the patient will raise this concern, you will ask about family history of dementia before the patient raised this concern. And this is not the right thing. Acute confusion is not dementia. So you can't ask about family history of dementia before the patient raised this concern. Once the patient tells you, doctor, I am concerned about dementia. Is it dementia, doctor? Then you can tell him, all right, why you are concerned about dementia? Do you have any family history of dementia? Okay? So this is in terms of being organized, non-scripted in consultation. Okay? In diagnosis, you have to give the right provisional diagnosis or range of working diagnoses. Working diagnoses. Let's take an example of this. A patient who is presenting with chronic dry cough. Chronic dry cough. The patient is a smoker. He traveled to Africa recently and he is a gardener. Okay, so what are your differentials in this case? You can think of asthma. You can think of COPD because of the smoking. You can think of TB because he traveled to Africa and the cough for a long period. Okay? Cancer is one of the differentials, but you can't think of it. You can put it at the end. You can't tell the patient the first diagnosis is cancer. You can't tell him, okay, I'm afraid that you have cancer. All right? So this is what I mean, or what they mean by giving range of working diagnoses. The diagnoses should be working to this symptom. Okay? Sometimes from the stress, the doctors cannot reach the diagnosis, the provisional diagnosis. If they don't reach the provisional diagnosis, so they will have a tick in diagnosis. Does that mean that they will fail the station? No. It depends. If they have explained their thoughts to the patient in a proper way, and they have done the management rightly, so they can pass. Okay? This is in terms of diagnosis. In terms of examination, you have to verbalize the relevant examination, and if it's a combined case or mannequin case, you have to do the relevant examination. When you start studying, you will find many people say this phrase: I would like to examine you from head to toe. From head to toe. This is not a right phrase for examination. Please avoid using this phrase. You have to mention the relevant examination. Let's take an example. A patient who is presenting with eye symptom, loss of vision. Okay? Is it proper to tell him, I will examine you from head to toe? No. The proper examination is checking his observations and examine his eyes. By that I mean examining the back of the eye by fundoscopy, examining the visual field, the visual acuity, and you can add neurological examination. That's it. So examination from head to toe is not an appropriate or proper examination in this case. Okay? If it's a combined case, you have to do the steps of the examination in the right way. You have to show the confidence in doing the examination steps. This is in terms of the examination. Okay? In terms of findings, findings are extremely important because findings can change the station extremely. They can give you findings in history, findings in examination, and findings in investigations. Okay? And based on the findings, if you picked up the right findings and you build the management plan based on them, so you will pass the station. Let's take an example. There is a case of tonsillitis. Okay? The patient will present with sore throat. Sore throat. In this case, they might give you a finding in the case, in the history taking. The patient will tell you, doctor, I am well in myself. I am well in myself. I feel fine, but I have just sore throat. Okay? In the examination, the observations are normal. All of the observations are normal. He doesn't have any fever, any problem in the observation. When you examine the throat, you find just mild redness around the tonsils. Okay? So, what is the treatment then in this case? Treating the patient as outpatient. You send him home, you give him an advice, taking paracetamol and gargling, and that's it. And you follow him up. Okay? In the same case of tonsillitis, they will change the findings. What they are going to do? The patient will tell you, doctor, I am unwell. I feel unwell. And in the observations are all over the place. His blood pressure is low, his temperature is very high, and on examination there is pus in tonsils. Do you think the treatment is outpatient treatment? No. The treatment will be admitting this patient in the hospital. Okay? So, do you know now how findings can change the management? And people, from the stress, don't think of it. They miss the findings. And it happens. It happens. Okay? So you have to be aware of changing of the findings in the same case. Okay? Issues. Each case has its specific issues, and I teach that in each case in the course. Okay? So each case has their issues, and you need to know what are the issues of each case. If you miss the issue, so you might miss the case. Okay? Let's take 2 examples for this. A patient who is presenting with acute loss of vision. Acute loss of vision. Do you think it is proper to ask about smoking and alcohol in this case? The patient can't see, okay, and he has acute, sudden loss of vision. Is it proper to ask smoking and alcohol? No, it's not proper. So avoid asking smoking and alcohol and lifestyle questions in acute or sudden cases. Okay? This is a kind of example for issues. Another example is a patient presenting with pain in loin going to the groin. Okay? And this pain is suggestive of renal colic. Renal colic. And the investigations are showing mild kidney impairment. Do you think telling the patient that we are going to admit you and involve the specialist is the very right treatment? Is it your job or the first job for you as FY2 is involving the specialist? Or what should you do first? You should stabilize the patient first. You should give him a painkiller for his pain, IV fluid for the renal impairment, and then you can involve the specialist. All right? So you have to think about the issues. Okay? In terms of language, you have to be simple, understandable to your patients. If you don't manage to do this, so you will have a tick in language. Also, if you don't understand the patient, you will have a tick in language. Okay? This is in terms of language. In terms of listening, you should show active listening. What is active listening? Active listening is picking the verbal and non-verbal clues. The verbal clues are everything the patient says. The non-verbal clues are everything the patient does. Let's take an example of verbal clues. Let's say that the patient is keep telling you, doctor, I am worried about my work during the station. And you don't even highlight that you have picked up this. All right? So you will have a tick in listening. How to highlight that you have listened? By 2 ways. The first way is telling the patient, I'm really sorry to hear that this is affecting your work. I will address that shortly in a minute if you don't mind. So you have highlighted that I've listened that it is affecting your work and I'm going to address that. Okay? This is if you are one who is getting panic when he get distracted by the simulator. So just highlight, tell him, I'm really sorry for this. I will address that shortly, if you don't mind. But if you are that focused one, you can address this on time. You can tell him, all right, I can see that it is affecting your work. Can you tell me what is your work exactly and how it is affecting your work? And then you can talk about the ideas or the things that you can support him in his work. Then you can come back to the history taking. So it's based on your preference and based on your way. Okay? This is in terms of verbal clues. In terms of non-verbal clues, the patient might showing you that he is holding his head, he has cannula, he's looking down. So you have to pick up these. You have to say, I can see that you are holding your head. I can see that you have cannula. I can see that you are looking down. Is everything all right? Okay? This is in terms of listening. In terms of management, we have talked about it. You have to formulate proper management plan based on each patient, based on their circumstances and their feelings, their worries. All right? This is in terms of management. In terms of rapport, you have to start your station by a nice way. You have to be friendly. Okay? And you have to maintain this nice relationship between you and the patient or your colleague throughout the case. If you don't manage to do this, you will have a taken rapport. Okay? Always the first impression is the last impression. If you start your station smartly, with a nice smile, with a friendly way, and you maintain that throughout the case, you will have high interpersonal skills. Okay? Let's talk about time. The last thing is time. Time doesn't mean that you need to finish the station in 8 minutes. Time means that you need to finish the important points in history and examination and in management in 8 minutes. Okay? If you finish all of the important points, but you still talking until the last minute, it's okay. As long as you have finished all of the important points, you are in safe side. Okay? This is in terms of time. Okay? This is a kind of picture from the GMC. It gives you an idea about the results in terms of quantitative domains. You will have the 16 stations. There are 18 here because it was before COVID. Before COVID was 18 cases, but nowadays it's 16. Okay, so you will have the cases, and in front of each case, the marks. Okay, and your total score that you get. There is no specific pass score for each case or for the exam, for the total exam. Okay, the pass score depends on the general performance of the candidates. If the general performance of the candidates is high in one of the cases, so the passing score will be high. You might get 7 and 8 and you don't pass. If the passing score or the general performance in a specific case is low, so the passing score in this case will be low. As you can see here, the passing score is 4.6. If you get 5, you pass the station. Okay, so it's based on the general performance. To pass the exam, you have to pass the score the pass score. Also, you have to pass 10 stations. Okay? To pass the exam, you have to pass the score, the total score, and at least 10 stations. If you pass the score and you pass maybe 8 stations, you don't pass the exam. Okay? If you pass the number of the stations and you don't get the score, you are not going to pass the exam. Okay? In this case, and in this picture, the candidate passed the score. The total score, or the pass score, is 107, so he got 120. How many stations he passed? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So he passed the number of the stations as well. Okay? And this is the quantitative mark domains. As you can see in front of each case, the skills areas. If you have a look, what is the main problem in the skills in this candidate? The management. 1, 2, 3, 4, 5, 6, 7. 7 ticks in the management. So the main defect in the performance is in the management. If this candidate is not successful, so he knows that the problem was in the management. When he tried to restart again, he can work on his management. Okay? All right. This is in terms of the marking. Let's talk about the NHS system. For your knowledge, the NHS system is very complex. And I'm going to give you the simplest thing about the NHS system. Okay? In the NHS system, we have primary care, secondary care, and tertiary care. Primary care is the front door of the NHS. It includes general practices. By that I mean in Arabic المستوصفات يعني, alright? General practices, community pharmacies, the pharmacies, dental centers, and ophthalmologists. If the patient wants to go to the primary care, he just will call the center, make an appointment, and he can go to the primary care without any referral. Okay? This is in terms of the primary care. In terms of the secondary care is the hospital services. In hospitals, you will find A&E, which is emergency department, and the other departments. Like what? Like neurology, ophthalmology, cardiology, respiratory, and so on. In each department, you find the wards for inpatients, for admitted patients, and clinics for treating outpatients. All right? What is the importance of this? The importance is you have to know where you are and what are you going to do. How to know where you are? From the question. They will tell you in the question, you are FY2 in the GP. You are FY2 in ophthalmology. You are FY2 in the hospital, in A&E. You are FY2 in the department, in respiratory maybe, respiratory department. So you know where you are from the question, okay? Once you know the context and the problem, then in the management, you will know where are you going to refer the patient. Are you going to then send the patient home? Or the patient is unstable, then you can refer him to the hospital, to the emergency department. Or maybe the patient has acute loss of vision, and you are in the GP, so you refer the patient to eye clinic right away in the hospital. Okay, so if you know where you are, you will, and you know the NHS system, you will know what is the next step. Okay, in secondary care, the patient should be referred. The specialists cannot see the patient without referral. The GP or the optometry or the pharmacist should refer the patient to the clinics or the departments in the hospital. Okay, the only two uh, uh, situations that the patient can go to the specialist without referral are: the first one, if the patient is going to the hospital right away in the emergency department, so the specialist can see them there in the hospital. They can treat them as an outpatient, or if he is unstable, they can admit him under a specific department. Okay? The other situation is gum clinic, sexual health clinic. The patient can go right away to sexual health clinic without any referral. All right? So, if you are in the general practice and the patient has acute loss of vision, we have talked about this, you will refer the patient to emergency eye clinic. What if in the question you are in the eye clinic? Do you need to refer the patient? You are already in the clinic. So you tell him, I will admit you in the department and we will do the investigations. Okay? This is in terms of primary and secondary care. Let's talk about tertiary care. In tertiary care, this is not our scope in PLAB 2, but for your knowledge. They are specialized consultative healthcare. So these are the hospitals which are specialized in specific cases. If the hospital doesn't have the facilities to do some surgeries, they can refer the patient to these hospitals, like cardiology surgeries and neurosurgeries. Okay, so they have the facilities and they are, uh, uh, you know, more equipped. Okay, this is in terms of tertiary care. GPs and hospitals can refer the patient to the consultative hospitals right away. All right, this is in terms of the NHS. Let's talk about the referrals, the types of referrals. We have immediate referral, very urgent referral, routine referral, and local arrangements. In immediate referral, the patient should be seen immediately, right away, like acute loss of vision. The patient should be, if you are in the GP, you have to refer the patient immediately to the clinic, to the eye clinic. All right, this is in terms of immediate. Very urgent referral, the patient should be seen within 48 hours, like osteosarcomas. If you suspect osteosarcoma, you refer the patient urgently. He should be seen in the specialist clinic within 48 hours. In urgent referral, it is the referral within 2 weeks. The patient should be seen within 2 weeks, not after 2 weeks. No, within 2 weeks. And this is the standard for what? For suspected cancer cases. If you suspect cancer, you refer the patient urgently within 2 weeks to the specialist or to the multidisciplinary team. Okay? In routine referral, the patient will be seen within 18 weeks. Within 18 weeks. Okay? What is local arrangements? Local arrangements are the local guidelines for each practice. As you can see here, each general practice has its PDFs for or its guidelines for each specific case. Okay, the NICE guidelines are national on all of the GPs and the hospitals in UK, but some GPs and hospitals in some towns and cities have their local guidelines. Maybe the NICE guidelines is advising to refer the patient in a specific case urgently, and in the local guidelines, the patient should be referred maybe immediately. So they will follow their guidelines. This is in terms of local arrangements. Okay? This is in terms of the NHS system. Now we are going to talk about the preparation. I will give you some golden tips about the preparation and then I will answer your questions. Okay? We are going to talk about the average time for preparation, courses and academies, sources, studying, practice, and mocks. Okay? These are the points of preparation in PLAB 2. Okay? Let's talk first about time. The average time to study is 3 to 5 months. Okay? 3 to 5 months is ideal. The ideal time. Less than 3 months, you put yourself in a risk to fail the exam. In my course, I do have 2 study plans. One is for 2 months, and this is mainly for repeaters. Okay? And the other study plan is around 3 months preparation. And I always recommend the 3 months study plan, because the 3 months study plan is more flexible, and also you finish everything in 3 months and you will have another month or maybe 2 months for revision. Revision is very important, extremely important. When you study something for the first time, you get maybe 50% of it. If you study it again, you will get maybe 70% of it. If you study it for the third time, you will get 100% of it. And this is a fact. This is a fact. Okay? So revision is always important. Try to manage to start your preparation as early as possible. Okay? Right? 3 to 5 months. This is in terms of time. Courses and academies. Regarding the courses, subscribe to the most suitable course for you. Whatever your decision is, go with it. All the mentors are very supportive. Every mentor has their own way of teaching, which will attract a group of people. If my way of teaching doesn't suit you, this doesn't mean that I am not good in teaching. It's just about my way is not fitting you. So if you feel that my way of teaching doesn't fit you, so you have to think about another course. All right? But once you decide and once you subscribe in one course, please stick to this course. Subscribe only in one course and avoid distractions between the courses, please. Don't spend your money to buy or to subscribe in all of the courses in the planet. Just one course is enough. Go with it and trust it, please. Trust it. Okay? Don't distract yourself. One course is enough. And by that I mean one full course. Okay? This is in terms of the courses. Academies. The academies are mainly for practicing, for the practical part. If you are going to subscribe in my course, I give you everything from zero to master everything, even the practical part. And going to the academy, it depends on the personality of the candidate. Okay, some of people panic when they see the mannequin and the sim man for the first time in their exam. So if you are this one who panic, so please go to the academy. 1 week is okay. Okay. If you are going to subscribe in my course, any academy will do the job. Any academy will do the job. I teach you everything. You just need to do some hands-on. Okay? If you are not that one who panic, you can go to the exam without any academy. I do have many people who passed the exam from the first attempt. They passed all of the cases of practical part with high marks. Some of them got 10 and 11s without going to any academy. Without going to any academy. All right? So the net result is it depends on your personality. Okay? This is in terms of academies. Sources. The best thing is writing your own notes. Okay? But if you want to follow a written note, there are free available notes like Aspire and All Days. I heard positive feedbacks about both of them. Aspire, free Aspire material, and All Days. Okay? And for your knowledge, notes are only for familiarizing yourself by the scripts. They are not for studying. They are not for studying. It is just a kind of written material for scripts only. But the management is not up to date in the notes. The management sometimes is too long, so you have a false perception about the management. You might follow the note and you go to the exam, do the station, and you don't pass because you have false perception about the management. Also, they are not approach based. They are not approach based. The exam is approach based. You have to know the approaches and you put the cases under each approach to deal with the cases smoothly in the exam. Alright? So if you are going to subscribe in my course, I teach you every single case, what are the possible concerns, how the station may come, okay? From A to Z, okay? But if you want a written source or a written script, you can just read the script and that's it. Alright? This is in terms of notes. So it's either Aspire or I talk about the free materials. Okay? Aspire or All Days. Okay? This is in terms of sources. In terms of studying, when you study, please study approach-wise and symptom-wise. What does that mean? You have to learn the approaches and what are the structure of each approach. This is for you when you go to the exam, when you read any new question, you just find out what is the approach of this question. Once you find out the approach, you enter the cubicle, you do the station smoothly, and you pass, in this case, with high marks, and this is a new case. Okay? So you have to learn the approaches and the structures of each approach. Okay? This is in terms of approaches. Symptom-wise, by that I mean, especially in history-based cases. When you try to study a case, study the symptom. Don't study the management only. Because when you go to the exam and you start the station, you will start by a symptom. And you need to reach a specific diagnosis from a specific symptom. So when you study any case, you have to know what is the presenting complaint that the patient can come with in this specific case. And you have to study how are you going to reach this diagnosis by asking the relevant questions. Okay? This is what I mean by symptom-wise. Okay? So, like chest pain, neck lump, what else? Breast lump, breast pain, the symptoms. You have to learn how to explore these symptoms properly and what are the relevant differential diagnoses that you can't miss in each specific symptom to be able to reach the provisional diagnosis in the right way. Then you can think about the management. All right? Then you can study the management. How to study the management? You have to think in the management about your role as a doctor. What are you going to do to the patient? And the patient's role. What the patient will do for himself or herself in the treatment. It is a mutual responsibility between you and the patient. You will do few things to the patient, and the patient will do few things to himself or herself. So this is how to study each case. The approach, the symptom, and then the points of management in terms of your role and the patient's role. Okay? This is in terms of studying. All right. Then practicing. Practice is the key in this exam. Yes, I do have some people who passed without practicing in the course. They just listened or watched the videos, but I can't put them the standard. The standard is practicing. Okay? So you have to practice with high quality practice. How to practice? Firstly, you can write down these points. Firstly, find the partner. You have to find a study partner to practice with him or with her on the cases. How to find the study partner? Once you join the groups of PLAB 2, write down or post in all of PLAB 2 groups. I am blah 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 blah. My exam is on the day blah 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 blah. I'm going to start from the day blah 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 blah. I want a serious study partner to practice with every day. Or every other day, from the time blah 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 to the time blah blah blah. And be consistent. Be consistent in every day, post this post, and you will find a partner. Once you find a partner, then you can start watching the videos and studying. Okay? You found the partner, and then you plan with the partner to watch the videos of the course, or whatever, of my course, or any course, any other course. You watch the videos, and then you read the script of the case from any note. Then you practice with your partner. You have to practice as you go. Please, 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 practice as you go. You have to do watching and practicing simultaneously. If you leave the practice till the end, you will forget everything. Okay? So you have to start practicing from day one. Even if you don't know anything about anything, just practice. You will build up every day a thing. All right? This is in terms of the, you have to watch and practice as you go. When you practice, you have to share the question with your partner. You have to give them time, 1.5 minutes, to prepare their mind. If you don't practice on this, on preparing your mind in 1.5 minutes during your practice, you are not going to do this in the exam. Okay? So you have to train yourself on the normal things that you are going to do in the exam to be a second nature of you. So when you have the stress of the exam, you are not going to think about them. If you don't train yourself on these small things, you will find yourself very stressed in the exam. You find yourself that you don't do well in each case. Okay? So share the question. Spend the 1.5 minutes in reading the question and finding the task. And then do the station. At first, don't think about the time. Okay? You don't need to finish in 8 minutes at first. What you need is just focusing on your way, on building up the skills of dealing with the patient, on maintaining the communication skills between you and the patient. This is what you are going to focus on first. Then, after that, you can think about the 8 minutes. Maybe 1.5 minutes before your exam, 1.5 months, okay, before your exam, you think about the 8 minutes. Before that, it's okay to practice more than 8 minutes. Okay? What else? If the station is face-to-face consultation or video consultation, try to switch your camera on. If you are practicing on just phone consultations without seeing your partner, in the exam, you will have a problem in your eye contact. And this will be a problem in the interpersonal skills. All right? So this is in terms of practice. Find the partner, watch the videos, read the script, practice on the cases of the video, and while you are practicing, share the question, spend the 1.5 minutes, don't think about the 8 minutes at first. All right? This is in terms of practice. In terms of mocks, take with whoever you are comfortable with. All of the mentors are working very hard and they are very helpful. But make sure that this mentor has experience in this field. not a one who just passed the exam. Okay, so when you take the mock, just make sure that this mentor has experience more than 1 year or something like this in PLAB 2. Okay, and I highly advise to take different mocks with different people. All right, this is if you can afford. If you can't afford it, it's totally okay. You can take one mock with an experienced mentor. All right. Maybe you can take, if you can afford, you can take 3 or 4 mocks. Um, maybe let's say 2 months, and then 1 month, and then 2 weeks before your exam. Don't take any mock if your exam is less than 2 weeks. Please avoid doing this. Avoid doing this. Don't take any mock if your exam is less than 2 weeks. All right? Okay, this is in terms of the preparation. Thank you so much, doctors. Thank you for listening. Thank you for attending. I hope it was helpful and it will help you in starting preparation very well. I am now going to see the chat box to answer your questions. Dr. Abdullah Abbas raised his hand. Yes, doctor. Hello.